Hello, I'm Bob Chaloner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, our monthly program about the events, people, and services at your community hospital. And today we're doing a show. We've invited in a member of our dental staff, actually, Dr. Gregory Davis, who is the chairman of our dental department at Southampton Hospital, and he's been a member of the hospital staff and a member of this community for 25 years. And I'd like to thank you, Dr. Davis, for being with us. And as I always like to do, tell us a little bit about yourself and how you ended up out here on the East End. I always find it's a fascinating story, and I'm also hoping you encourage other professionals to join us out here.
Well, I am a Long Island native.
Okay.
I started in East Meadow.
East Meadow, okay,
Yeah.
great.
And people from East Meadow never came any further than Jones Beach.
Really?
No further east than that.
Yeah.
So the Hamptons were an unknown entity to me. But
it is interesting to me the way Long Island people tend to be. It's a community where people really do grow up and stay for their whole lives, and even the communities are very specific.
Which I think says something nice for it. If people are willing to stay and stick around, it's a good sign.
Absolutely, it's a very good sign.
But I went off to college. I went to SUNY Albany, and then I went to dental school in Boston to Harvard, and then after that I stayed there, did my specialty training, and had a couple of good offers in Boston and New York City, but Long Island was really always feeling like home.
Wonderful.
And we just happened to stumble onto the East End by chance, and my dad, who's a high school teacher, retired now, was at a reunion of students from the 1960s.
Oh, really?
And asked them, posed the question to them, what advice would you give your son if it was your son who was looking to come back to Long Island and get started? And they all said the same thing: go as far east as you could.
Really interesting.
And that's what brought me out here.
Yeah, you don't get much further east than
and
that.
it's hard not to fall in love.
Yeah,
it's
sure
a beautiful
is.
place to be.
Do you live right in Southampton?
Yeah,
Okay.
yeah.
Great, wonderful. I know you have a family and some children also, so
yeah.
wonderful. Well, we're certainly very, very happy to have you on our staff. Tell me a little bit about your dental training, and people always love to hear, after college, how many years of dental training?
Okay.
Did you do any subspecialization?
Sure.
Yeah.
So dental school is typically 4 years, but at the time I was attending Harvard, it was a 5-year program, which is
yeah, that's a long time.
Which is a long time and a lot of years to pay tuition. However, they had a very interesting circumstance in which you could, if you chose to specialize and you chose to stay there, you could use your 5th year of dental school as your first year of your residency, which is something that I did. And so my 3-year residency in periodontics, which is what I did, was a total of 7 years for me instead of 8. So it worked out beautifully, and it's the same as if I had gone anywhere else. But the education was really something, I think, very special. The doors that were open for you were really wonderful.
From start of college to actually getting out into the real world?
Yeah, 11 years.
Wow.
11 years, and it was a lot. It was a lot of years of tuition payment and a lot of student loans.
Very impressive.
But it was a fun time.
Tell us about periodontics and what that is also.
So periodontics is actually a field that's evolving almost day by day. But periodontics deals with that aspect of dentistry which is involved in maintaining and treating the supporting structures of the teeth, the gums, the bone, the things that help your teeth stay in your mouth, if you will. But with the advent of dental implants, periodontists are very actively involved in site development for dental implants, placement of dental implants, elevation of sinuses to create space where there is none, where you create bone to place dental implants, and also oral medicine, which is what brings us on topic for today. Oral medicine is an important part of dentistry as a whole, but periodontists are especially attuned to the soft tissues of the mouth and reading the subtle changes that occur, many of which look the same. Many conditions manifest primarily in the oral cavity, and if you can pick up on the subtle changes, you can often detect disease quite early.
Great. Well, one of the topic for the day is oral cancer, and I know that April is Oral Cancer Month.
Yes, it is.
And as we do a lot of the diagnoses, people really just don't fundamentally know what these things really are. So let's just start talking about it. What is oral cancer?
Well, oral cancer, like any cancer, is uncontrolled cell division of an abnormal cell that's just gotten out of control. But in our case, it's happening somewhere within the tissues of the oral cavity. It could be on the tongue, the floor of the mouth, the oropharynx, the lips, the mucosa, the gingiva. So all of these areas should be inspected on a regular basis.
Okay, and we're going to be doing, I know we'll talk about that a little later, we are going to be doing a screening for oral cancer, and we'll talk about that and how you're doing it. But let's just talk raw numbers. How many cases of oral cancer in the U.S.?
There's about 50,000 new cases diagnosed every year.
50,000?
50,000.
Wow. I had no
It's
idea.
more prevalent than thyroid cancer,
Wow.
cervical cancer, Hodgkin's lymphoma, testicular cancer.
Right.
So it accounts for nearly 5% of all new malignancies.
It's funny, you don't seem to hear about it quite as much either. What do you
No.
think that is? Why is that?
Well, part of it is the fact that it's really not detected too often.
Okay.
A lot of it goes undiagnosed, and if left undiagnosed for a period of time, it will metastasize. It has a very high rate of metastases, and so oftentimes people wind up being diagnosed with other types of cancer that are already stealing life from them.
Right.
And so the oral cancer doesn't really get the acknowledgement.
Right, and that may have been
As
the
the
primary
primary,
site.
sure.
Okay. What are survival rates like with oral cancer, 5 years?
5-year survival rate is just slightly greater than maybe 50%,
Okay.
and that's not very high.
50%.
5-0,
Wow.
yes. And the reason we think is because it is seldom picked up in time.
Okay.
When caught early, oral cancer is very treatable, and the prognosis is quite good. Many of the lesions can be caught in situ, and they're actually very small and haven't had a chance to spread through the tissue layers at all.
Okay.
But if you don't catch it until it's penetrated deeper into the tissues or started to spread throughout the body, the prognosis is very poor.
That's not good. So clearly the screening that we're going to be talking about is going to be very, very important. So,
Yes, absolutely.
and I know that, like, well, with many diseases, there are risk factors. And first of all, men and women, are there any differences in men or
Yeah,
women?
men seem to be more predisposed than women, probably almost 2 to 1.
2 to 1. Interesting. Any thoughts on that, or why?
Yeah, probably behavior.
Yeah.
More alcohol, more smoking,
Okay.
traditionally, I would think, is part of the equation.
Okay.
But I also think that there's been a paradigm shift in what the risk factors for oral cancer really are,
Okay.
and who's at risk.
Okay.
Traditionally, it was 40-plus-year-old males
Right.
who smoked, who drank,
Right.
who had some kind of other exposure to something that could be carcinogenic, or a history.
Chewing tobacco.
Chewing tobacco being a
Right.
big one.
Okay.
But the new growing segment of the population that is beginning to eclipse the smokers and drinkers are the sexually active 20-somethings that are bringing into play the whole development of oral cancer from papillomavirus.
All right. Yeah, and I do want to talk about that and hear a little bit. I know who was the actor that kind of publicized
That was Michael Douglas.
Michael Douglas, exactly right. So what about some other risk factors? Any racial groups or?
Well, African Americans seem to be at slightly higher risk
Right.
than Caucasians, and other than that, it's the sexually active population that seems to be climbing in the numbers right now.
Okay.
And alcohol and smoking groups seem to be sort of steady or even falling relative to that group.
They are.
So, risk factors, can be environmental. They can be, sun exposure. It
Right.
can be exposure to carcinogens
Sun
in the
exposure
workplace.
also?
Sun
like
exposure,
skin
right?
cancer?
Exactly.
Okay.
On the lips, mostly.
When we're talking about oral cancer, and just I'm kind of interested, what part of the mouth is it that's really affected?
So a proper oral cancer exam
Right.
needs to look at all the oral tissues.
Right.
However, there are some areas that we know are much more prone.
Okay.
For example, the lateral border of the tongue
Right.
is a very common site.
Lateral side
The side,
border?
the
Okay,
side
right.
of the tongue, the sides of the tongue, but also underneath the tongue on the floor of the mouth.
Okay.
And if you can, and any proper oral cancer exam should have a moment where the tongue is retracted and pulled out of the mouth with a gauze, so you can really see as far back on the base of the tongue as possible.
Okay.
Because the oropharynx and the deeper structures are sometimes where the papillomaviruses tend to hide and cause growths that really aren't visually detectable
Okay.
in some people.
The papillomavirus, this is the virus we hear about often with immunizations for children now. And
Correct.
What exactly is this virus, and what's going on there?
Well, the papillomavirus it's a common virus,
Right.
but it has the potential to cause tissue growth in response to the infection. And when it does, a high percentage of certain types of papillomaviruses become malignant.
Right.
And it was a big problem with cervical cancer, and that's where they first identified that I think it was HPV, human papillomavirus, I think 16 and 18 were really highly associated with the development of cancer.
Right.
And that seems to be the case for oral cancer as well, not just cervical cancer. So the vaccinations that are presently available tend to focus on, I think, 4 of the papillomaviruses. I think it's 6, 11, 16, and 18, which are the ones that seem to be the most carcinogenic.
And I've heard it said that the virus is typically, the reason why we're trying to vaccinate younger kids is because once people become sexually active, there's a good chance they've already been exposed to it. Is that
Correct.
Is that true?
You want to try to vaccinate them before,
Before
and,
they get it.
and unfortunately, that age is dropping all the time.
Okay. And is it fairly prevalent in the population, the HPV virus? Or?
Yes, it is.
Okay.
Yeah, so it's a definite concern.
Okay. What is it exactly that you're looking for when you do the examination in the mouth? What's it? Is it something that a layperson would be able to,
Sure.
some people get canker sores or fever blisters. It sounds like it's clearly something
So for the
different from that.
layperson to be looking for, they should be looking for things like a persistent sore or a non-healing ulcer, a lump, a bump, a thickness in the cheek, a swelling, the onset of pain with no obvious dental implication, development of numbness somewhere in the oral structures, the tongue, the cheek, the gums, swellings or lumps in the neck. Difficulty swallowing is most always associated with the cancer. So that's what a layperson should kind of be tuned into. For a dentist doing an examination, we're looking at a visual inspection of the gums, the floor of the mouth, the sides of the tongue, all the surfaces of the tongue, the palate, the soft palate, the hard palate, the lips, the cheeks, and as far back as we can see around the tonsils and down the throat.
And you're obviously trained to spot it at probably a much earlier stage than most people would even notice. So.
We are, and we're looking, and we know what we're looking for. And we're also feeling, we're doing a bimanual palpation of the floor of the mouth. We're doing a manual palpation of the nodes, the anterior cervical chain, posterior nodes. We're looking at we're palpating the thyroid. We're looking for the trachea to determine if it's midline and movable, and make sure there's no hard indurated masses that are anywhere in the oral cavity, that everything feels good.
Right. Okay, interesting. And you talked about the importance of screening it, and it sounds like if it's caught early, is it actually curable?
It is.
Okay.
It is actually curable, a lot of times just by surgery.
Okay.
Surgical excision can be curative if it hasn't really spread. Sometimes radiation is necessary.
Okay.
In the cases where radiation is necessary, there's a whole nother level of care that needs to be attended to, because radiation therapy tends to reduce salivary function or kill off the salivary glands altogether. And so patients with reduced salivary function are at much higher risk for decay and development of a condition we call mucositis, which is just a really sensitive, sore, highly inflammable oral tissue situation, which can be very unpleasant, makes eating and drinking very difficult and painful. But from a dental standpoint, we're also concerned about the onset of decay. A lot of these patients with dry mouths suddenly, for the reason of no other reason than their salivary flow has diminished, are much more susceptible to decay. And the amount of decay can happen very quickly, within weeks, within months, and some or all of the teeth can literally rot away.
Really? Just from the lack of saliva?
Just from the lack of saliva. Saliva has a lot of very protective components in it, not the least of which is a secretory antibody that actually fights bacteria. And it's a buffer. It neutralizes acid, so there's a lot of benefits from saliva. So oftentimes patients that are about to undergo radiation treatment are seen first to be fitted for custom fluoride trays, which can be really helpful in preventing the decay.
Is that something they wear routinely to give themselves fluoride? Or?
Yeah, it's something they would put in at night and maybe line the tray with some fluoride and either leave it in there overnight or leave it in there for a couple hours a day just so they get proper fluoride
Okay.
to the tooth surfaces. It's not a guarantee. They're not going to get decay, but it certainly helps to push the deck in their favor.
So the surgery, radiation, I mean, clearly there's probably, it depends on the amount of disease that determines. Most people don't automatically need radiation. It may be treatable just with surgery.
Correct.
So it also sounds to me like I think most of us think about going to the dentist and getting our checkup for cavities, but this sounds like it's almost more important than just the cavity check. So which are obviously important also. I don't want to undersell that, but it's clearly this sounds like something we should be routinely getting checked. How often would you say people should be screened?
Well, every time you go to the dentist,
Right.
you should be screened
Okay.
for oral cancer. And we do oral cancer screenings at every visit for
Okay.
every patient that comes in for a cleaning and at every new patient exam.
Okay.
And at the very least, at least twice a year when people go for routine visits if they're reasonably healthy.
Right.
Which brings me to a point that I actually think is very important to make, which is that a lot of people don't feel they need to see a dentist if they don't have any problems with their teeth
Right.
or mouth that they perceive, or if they have dentures and think that they no longer need to see a dentist because they don't even have teeth.
Yeah, absolutely.
And that's not true, because oftentimes one of the presentations of oral cancer is sort of a change in the fit or the stability of a denture.
Really?
So that may be the only tip-off, or a non-healing sore or an ulcer underneath the denture. And sometimes some people don't even remove them. They don't want to be seen without teeth.
Right.
They leave them in all the time, and when you do a proper exam on a patient that has dentures, you have to remove them. You have to check all the oral tissues underneath, because that's oftentimes a hiding place for cancer.
For cancer.
That gets missed a lot.
And a couple of the factors we talked about, it's more likely in men than women. It's, certain, racial groups. But also, what about things like age? Are we more, is cancer, a lot of cancers, are you more likely to, or more susceptible the older you get? Is that possibility here too? Or?
Well, it is. It's possible to hear, and until maybe 10 years ago,
Yeah.
that was probably true, but it's not anymore. The most rapidly growing segment of the population is now a much younger, healthier group, and it's because of the papillomavirus.
It is.
So
Okay.
the smoking and drinking population getting oral cancer is not as significant. It's not as growing an area. So
Seems like there's fewer smokers, but.
well, there are, but there's still plenty of drinkers,
Yeah,
that's for
that's
sure.
true, that's
And
true.
there does seem to be a synergy between
Yeah.
them. So even if you're a light smoker and a drinker, there's a lot of synergistic effect of alcohol and tobacco.
Okay, so alcohol itself, by itself, is a potential risk factor?
Yes,
Okay.
absolutely.
Interesting,
Mm-hmm.
yeah. I mean, so often now we hear about, it's have that glass of wine with dinner or whatever, it's good for your heart, but there may
Right.
be some other factors.
Well, like everything else, you have to think about moderation.
Right,
And you
right.
have to assess the risk in all the things that you do.
Right.
And certainly no one's advocating, cessation of all alcoholic
Right,
consumption
exactly. Yeah.
to avoid oral cancer. But
Yeah.
certainly it behooves us to be checked
Careful and check.
and know that you've been checked by a proper exam, and know what a proper exam should be like and should feel like and should include. And the easiest thing I tell people is to just, if your dentist or hygienist hasn't pulled your tongue out with a gauze and pulled it from side to side to look back there,
Right.
then you probably haven't had a proper oral cancer exam.
Okay. I remember the first time my dentist did that to me. What is he trying
What's
to do?
going
Pull
on?
my tongue out of
Right.
my mouth? Exactly. What about people that were former smokers, maybe have given up smoking? Are they, are they at a heightened risk?
Well, after 5 years,
Okay.
they say the risk of a non-smoker that was a smoker is the same as the risk of
Right.
someone who never smoked.
Right.
So I would think that stopping is very beneficial
Right.
and does reduce your risk at a certain point in time.
And you talked about younger people. How young are we seeing it?
The 20s.
Really?
Yeah.
20s.
Yeah.
Okay.
And it's not just from the HPV. I don't want to make
Right,
that sound like
right.
it's all about HPV.
Right.
It's not. There's a lot of products out there that young people have been embracing, smokeless tobacco,
Okay.
snooze. There are products that people put in their mouth
Okay.
that sit against the oral tissues and are highly carcinogenic. And shockingly, you don't see a lot of acknowledgement of the risk
Really?
in young people.
Yeah.
They just seem to be concerned with doing what they feel they're comfortable and want to do, they still feel invincible in their 20s,
Right.
and they haven't, life hasn't caught up with them yet.
Right.
And that is where the population of new oral cancer growth is
Starting
being
to-
seen, and it's unfortunate.
Any foods or things that people are eating that may be putting people at risk, or any?
I think it's mostly the alcohol.
Right, okay.
And I guess there are some foods that might have potential carcinogens in them,
Okay.
but nothing really specific.
Clearly linked to it. What about sports figures? You always see sports figures, pitchers up on the mound chewing tobacco and things. Is there a link there?
Yeah, oh, absolutely.
Right.
Professional athletes were a
Right.
big area of those types of oral cancers, and it's very unfortunate
Okay.
because they are role models for
Yeah,
young
for
people,
younger people.
oftentimes,
Right.
and kids just want to be like their heroes,
Right.
and it's a bad example to be set.
If I've been found to have an oral cancer and it's been removed and things, it sounds like that's pretty good. But what about recurrence rates?
Recurrence rates can be quite high, depending on when it's caught.
Yeah.
If the cancer is caught very early, recurrence rates are quite low, but recurrence rates go up as the extent of the cancer increases.
Okay.
So if something has had a chance to penetrate into the deeper tissues, invade the lymph system, or metastasize, then the risk of recurrence is quite high.
Okay.
Oral cancers do recur.
So obviously,
Early
folks that
detection
have had it in early detection and early then ongoing monitoring.
and ongoing monitoring is key.
What about precancer? Is there a precancerous form of oral cancer?
Sure,
Yeah.
sure. We call that dysplasia. Cells that don't look quite typical
Okay.
on a microscopic stage, but aren't actually cancerous. They're not multiplying at a ridiculous rate. They're not invading deeper tissues,
Okay.
but we don't like the way they look. Typically, those lesions need to be watched the closest,
Okay.
and really biopsied periodically if there's any sign of change.
Right.
Sometimes I know in some places they do some laser therapy to some of these dysplastic areas to kind of periodically strip the epithelium and try to keep it healthier. But there are people who specialize in doing that type of treatment. There are
Okay.
oral pathologists and
Okay.
head and neck surgeons that engage in that kind of thing. But for the most part, dysplastic lesions are things that should be documented with photographs
Right.
and descriptions and followed very carefully.
Sometimes people have this notion that, oh, I've got a spot, I don't really need to worry, or I'll check it a year or two from now. How quickly do
Quickly.
these precancerous or a cancerous lesion, I mean, how quickly should you get screened?
You know, they're dysplastic until they're not.
Okay, okay.
And depending on when things start to change and things start to spread, I mean, if you're seeing your dentist every 6 years, that's probably, every 6 years, excuse me, every 6 months, that's probably going to intercept things before they have a chance to get too far away from you.
Okay.
But waiting a year or two is way too long.
Really?
And sometimes even 6 months can be too long.
Really?
So it's really hard to say because it depends in every individual, the susceptibility of the host is always a big factor.
Right,
Some people are more resistant, some people are more susceptible.
right.
Some strains, some variations of cancers are quite aggressive.
Okay.
Some are less so. This squamous carcinoma that we spoke about is 90% of oral cancers.
Okay.
10% can be adenocarcinomas, glandular. They tend to be a little more aggressive.
Okay.
But the squamous carcinoma spreads
Right.
pretty rapidly. So, early detection in all cases.
You talked about some people that are a little more susceptible. Is there a genetic link to it? Or have
Yeah.
they shown a genetic link?
There are
yet?
some, people who are susceptible to certain types
Right.
of breast or ovarian or colorectal cancers tend to have a little bit higher
Okay.
occurrence of oral cancers, and so there's definitely genetic susceptibility. If you have family members, multiple family members who've all had some form of cancer or a history of oral cancer, should really be thinking about getting checked a lot more closely.
They should be,
Mhm.
okay. What about a link to skin cancer? I mean, sometimes, I know they're different tissues, but they're kind of, is it, and you talked about squamous cells.
Well,
Is
they're
there
really
any link
not
to-
different
Yeah,
tissues.
okay.
The skin of the face becomes the lips,
Okay.
which becomes the oral mucosa,
Right.
which becomes the pharynx and the oropharynx,
Okay.
and so in many ways it's not very different at all. And the
Right.
lips are considered part of the oral cavity,
Okay.
and they are very susceptible to sun damage.
They are. Yeah,
Yeah.
it's kind of hard to keep your. What would you recommend for that? I mean, balms or whatever?
Sunblock, lip
Yeah,
balm with an
yeah.
SPF of at
Okay.
least 25 maybe would
Okay.
be probably a good place to start. And sun avoidance is my best recommendation.
Okay.
I've
Well-
made a habit out of sun avoidance. I think
Yeah,
it's
Yeah.
I think it's good on a lot of different accounts.
Yeah, no, I think you're right. We
Yeah.
get out there, we love the outdoors, but certainly in moderation, like everything, it sounds like it makes a lot of sense. So somebody who's at risk or has had some skin cancer, probably there could potentially be a link. So.
I think anybody that's had any
Yeah.
kind of cancer should
Right.
always be looking closely for any
Okay.
kind of spreading
Okay.
cancer. A history of cancer always makes us that much more concerned
Right.
about being thorough and not missing anything in the oral cavity, because we see that a lot.
Right.
There are.
It almost seems to me that, given the risk factors, and it's kind of hard to avoid putting things in your mouth, especially eating, and it's not a difficult exam either. I mean, it
No.
doesn't sound you're not
Painless,
taking
simple.
biopsies unless
No.
you find something.
Right.
Right. Okay.
It's a simple exam. It takes
Right.
about 5 minutes,
Right.
and it couldn't be easier.
Right. And are all general dentists trained to do this? Is it something that most
Every
are?
every dental school is training dentists to do
Okay.
oral cancer exams. Whether they're doing it in practice or not is a separate issue.
Right.
Many offices have the dental hygienist do the exam.
Okay.
But the dentist should get involved
Right.
in looking and checking and double checking, because it's always better to have a system of checks and balances, have an
Right.
extra pair of eyes
Right.
checking on things. But yes, every patient, every visit should certainly be looked at. And if anything strange is found, it should be documented and followed up. And any lesion in the mouth that doesn't heal in 2 weeks should be biopsied.
How would you feel about a patient if a dentist isn't doing it, the patient's actually asking for the check? I think most dentists probably would, but do you think the patient should be looking for that routinely?
I think
that
they
check?
should. I think the best defense against oral cancer is public awareness and public
Right.
education. And if patients know what to ask for and what a proper oral exam is,
Right.
then they can at least seek it out. And if they're not getting what they need in their office, they should go elsewhere,
Okay.
because that's a very important part of a dental visit.
It sounds
And it's
like
not
it.
getting looked at by any other healthcare providers as a rule.
Right. Yeah, I can't think of a primary care physician who's
Looked under your
typically
tongue?
looking under my tongue.
Or at your
Exactly right.
gingiva?
Exactly right. Exactly right.
Yeah.
It sounds like a very important part of what we're doing. Any of the dental treatments that we do, fluoride treatments or mouthwashes or whatever, anything potentially preventative?
I would say no.
Okay.
I don't
okay.
think you're preventing oral cancer through any of the dental medicaments or rinses or toothpastes or
Okay.
any of the products like
I
that.
just had to ask because lots of times we deceive ourselves into thinking, oh, if I come up with this home remedy once a day or something, it'll prevent, it'll take care of me, but nothing that you know of that's been shown.
No, not for preventing oral cancer. No.
Okay, okay. So let's just very quickly, and I know we want to talk about the screening that we're going to be doing. Just quickly again, maybe some symptoms or signs that people should be looking for.
So a non-healing ulcer in the mouth,
Okay.
a sore that won't go away,
Right,
pain
right,
that doesn't seem to have an obvious dental origin, a thickening or swelling in the cheek wall, any sudden onset of numbness or tingling in the mouth, difficulty swallowing, any lesions that don't look right, red lesions, white lesions in the mouth that you don't remember ever having been there before.
right.
Those are pretty good indicators that you need to be seen
Okay.
and have it evaluated.
And again, it sounds like the absolute best approach is to get that screening. Just from your own experience, how often do you see oral cancer out here?
So in the last 25 years,
Yeah.
we've picked up about a dozen cases.
Yeah, wow.
So it's out there.
Yeah, it is out
And you never want to miss it.
Right.
Because the implications are tremendous.
Right.
And the earlier you intercept it, the prognosis is so much better.
Absolutely.
That it's a tremendous service to your patients.
Absolutely. Just tell us about the screening that we're going to be doing. What are you actually going to do?
So,
do they need to disrobe? Do they need to bring in a urine sample? What exactly?
Fortunately,
what's going to happen?
Fortunately, none of those things.
Okay.
So all someone has to do to attend the free screening is show up.
Okay.
We'll have them fill out a little bit of paperwork,
Okay.
sign a consent,
Right.
and sit down in a chair. We'll shine a light in their mouth
Right.
and take a look around using a dental mirror and a tongue depressor and a piece of gauze.
Okay.
And we'll look at the oral tissues, we'll inspect the lips, the cheek, the gums, the tongue, the floor of the mouth, the oropharynx. We'll do some bimanual palpation of the floor of the mouth. We'll feel the neck for nodes, enlarged lymph nodes. We'll feel the trachea, the thyroid, move things around, make sure there's no masses, lumps, bumps, things that don't move right.
Right.
And that's about it. And it's simple, and it takes less than 5 minutes.
All right. Sounds like the best 5 minutes we could spend. And April is oral cancer.
And April
month.
is Oral Cancer Awareness
And
Month.
the whole purpose of these kind of disease of the month, it's really about spreading awareness, and that's what our real goal with this is. And I understand you're doing this, you're volunteering this, there's no charge for the screenings?
No,
for
it is a
people?
free screening, and we're happy to do anyone that wants to come.
Wonderful, thank
Yeah.
you. Thank you so much.
My pleasure.
And that screening will be on Monday, April 3rd, and it will be dentists on our staff here at Southampton Hospital. It will be 6 to 8 p.m. in Parish Memorial Hall, right where we're sitting right now, and we do welcome walk-ins. So please take advantage of this, especially if you haven't seen a dentist in a while. Take advantage of this a great service that you're offering. So Dr. Davis, I'd like to thank you and the entire dental staff here at Southampton Hospital. We have how many dentists do we have on staff? Do
We
you?
probably have about 15 or 20.
That's what I thought.
Yeah.
It's a good-sized,
Yeah.
very professional, wonderful group of people. But I just want to thank you for being involved with the program today, and also all the great work that you're doing, and particularly this screening. So, and as always, I'd like to thank our friends at CTV for the wonderful job they do of producing this show and airing it in our Southampton communities, and also our friends at LTV for airing the program in our East Hampton communities. I'd like to thank you for watching today. Please do not hesitate to call us if you'd like some additional information about the screening, you'd like to talk to Dr. Davis more and get in contact with his office. If you have any questions or concerns about your health care and navigating the health system out here on the East End, we're here to help. And my number is 631-726-8555. Please feel free to call. Thank you, everyone, and good health.